Looks like the trauma session is going to be a little traumatic with very few people. Anyway, so to start off, as you know, this ocular trauma is basically a comprehensive one which involves all the subspecialties right from cornea to neuro-ophthalmology. So here are my contributors to this talk from various departments. So briefly, over the next 30-35 minutes, I hope to cover a bit on the terminology on ocular trauma, the ocular trauma score, pathophysiology of blunt and open globe injuries and their consequences, initial evaluation of a patient as a whole, the spectrum of ocular and adnexal trauma, general principles and the concepts of management, including the surgical aspects, a note on traumatic optic neuropathy, imaging, that is CT scan versus MRI, and if time permits, we could just briefly go on sympathetic ophthalmitis, documentation, medical legal aspects, and various controversies. As you know, ocular trauma is full of controversies. As PGs, I feel these are the two books that you guys need to know and go through, because this gives a comprehensive outlook on the ocular trauma per se, especially the globe. How many of you have heard of BETT? What is BETT? Anybody knows what is BETT? Yes. So why do we need these terminologies? Is mainly for the transmission of data between the ophthalmologists to communicate, that is basically, to facilitate the optimal patient care. So what should an ideal trauma system contain? So they should know what the tissue involved is, providing a clear definition of the injury type. So what is the type of injury? You just can't say globe injury and just leave it. So you have to be very specific when it comes to the ocular trauma. So this was by the Birmingham Eye Trauma terminology. So this was endorsed by the various academies, and they satisfied most of the whatever was necessity in that. And they had certain glossary of terms, like an eye wall meant either the cornea or the sclera. So if you say eye wall injury, that means it should ring in your mind that it is cornea or a sclera. And if it is a closed globe injury, meant there was no full thickness injury to the eye wall. Again, the eye wall, so you should know this eye wall. An open globe injury was a full thickness wound of the eye wall. And contusion, again, here is a no full thickness injury, but injury here is either due to the direct energy delivered by the object or because of the change in the shape of the globe, and mostly by the what causes the change in the globe shape of the globe or the internal aspects is the blunt trauma. So the lamellar laceration was the partial thickness wound of the eye. Rupture was a full thickness wound, like in, is there a pointer? Yeah. Mouse only, okay. Yeah. So a partial thickness was the full thickness, and laceration usually was a full thickness caused by a sharp object. Penetrating injury, like in this patient, was an entrance wound and the retained foreign body. And a perforating usually would be an entrance and an exit wound caused by the same agent. So when you say penetrating injury, that means you should think that there could be a retained foreign body in the eye. Or if there is a laceration, it means it is because of the what? Sharp object. So these are the key terms which should say what kind of trauma that is. And each injury in a framework, meaning any of these, like suppose you say it is a penetrating foreign body, that means it is an open globe injury. If you say contusion, that means it is a closed globe injury. So you can just picturize it when it is in one framework. And this ocular trauma classification group, they came up with something based on the mechanism of injury, initial visual acuity of a patient, pupillary movements, and the location of the wound. That is the most posterior location. Where was the last posterior location of the wound? So likewise, if you just say now, open globe injury, type B, 2, negative RAPD, zone 2. That means it should say that the wound is in the limbus, from between the limbus to posterior 5 millimeters of the sclera. There is no RAPD. That means your optic nerve functions are intact. And if they say visual acuity 2, that means you have to know that there is a reasonably good visual acuity of 618 to 636, and it is a penetrating injury. So if they give these codes, that means it is, you can come into these, you can expand the code. Likewise in the closed globe as well. And what is this ocular trauma score? Can anybody tell me what is this ocular trauma score used for? Prognostic factor, exactly. So it is the 6-month prognostic factor. So how did they give this scoring? They gave some raw points here. Like you can see these raw points which are here. Based on the variables used, there were various variables used, and the sum of it was the raw point. Like suppose an example, if the patient had a visual acuity of 1/200 and a scleral rupture in RD, the raw OTS would be a sum of that. That would be 80 minus 23 minus 11, so that would be 46. And based on this, they gave the ocular trauma score. So every raw OTS had a OTS adjoining to it. So in that patient, probably the OTS would be 2. That means his visual acuity of 20/40 would be only 15%. So higher the OTS, better the prognosis. So now you have done the theoretical aspect of OTS and BETT and all that. So what would you do when the patient comes to you with a trauma? Take a step back here. I mean literally take a step back and see patient as a whole. Because most of you might not be in just an eye hospital. You could be in a general hospital and you could encounter various other subspecialties as well and know the ABCDE of trauma. That is the airway, the breathing, the circulation, the disability, and you might have to expose a few parts to see what exactly is the injury. Polytrauma may involve other systems, record all the vitals, the mental. You're a doctor first, so you have to see that portion also. So the mental status and the quick examination of the fractures for respective areas, referrals. And if you feel that patient has got an unstable vitals, impaired mental status, serious non-ocular injuries, and if you think you're not capable of handling it, kindly refer. So what are the general history that you need to take here? Because your basic examination, again, depends upon the general history, because most oftentimes we might have to take up the procedure under general anesthesia, so it becomes very important to know when the last feed was. Most often we forget that unless the anesthetist tells us when was the last feed done, then, the bulb rings. Oh yeah, when was it? I forgot to ask. So have that in your mind. Know the systemic ailments, all the medications. Are they allergic to anything? Was there any bad history as far as the general anesthesia was concerned? All this should be there in your mind. Then coming to the ophthalmology evaluation per se, a detailed mechanism of the injury, whether it was a sharp injury, whether it was a blunt injury, whether he was a bystander, because most oftentimes the bystanders are the ones who get injured than the person who is involved in the work. So exact time of injury, because if it is a medico-legal case, it becomes important to know that what was the place of injury, what was the material, because organic foreign bodies versus inorganic foreign bodies, iron foreign bodies, these all can cause certain reactions. So if possible, get to know the history, to know what was the material of the foreign body used. Most oftentimes they come with a small piece of residual one which they either plucked it off from whatever was there, or if there was a blast injury. So it's very good to know what type of metal was involved, or if there was any prior ocular history. Then coming on to the external examination, including start from the lids, lid laceration, ecchymosis, edema, ptosis, enophthalmos, exophthalmos, all that you should know. And if there is any protruding foreign body, prolapse of the ocular contents, crepitus for the orbital margins, infraorbital nerve paresthesia. Why is the infraorbital nerve paresthesia important? Sorry? Why is it important? Blowout fracture, exactly. So you'll know that it gives you a hint that probably there could be a blowout fracture, there could be a floor fracture. See, this is, again, you can see that there is enophthalmos, so that again gives you a clue that there could be a blowout fracture. And many a times, the small lacerations, we feel like, are like, oh, they're very small, but actually when you look into them, they will be quite huge. So EUA is like really important. And needless to say, visual acuity, check for the RAPD, look out for ocular motility. Again, this patient has had a blowout fracture, the floor of the orbit, so you can see the elevation is restricted. Why is the elevation restricted, anybody? Entrapment of the inferior rectus, or even the entrapment of oblique, and even fat. Fat to a certain extent can cause some amount of restriction of elevation. If you go stepwise, that is from the conjunctiva, layer by layer, you will not miss out anything. But again, what the mind knows is what the eye sees. So unless you know what you have to see, you might miss out. It could be as simple, small foreign body like this, small conjunctival laceration like this, or it could be a small SCH. But when you see a bullous SCH like this, then it should just give you a probability that there could be a fracture. This is called the hemorrhagic conjunctivitis, chemosis. Lamellar defects, again, full thickness laceration. What is Seidel sign? You can see the Seidels I have put. What is Seidel sign? What is Seidel sign? Huh? Fluorescein. What do you do with fluorescein? Yes. And what do you see it? What filter do you use for that? Good. So, and always assume open globe injury unless proven otherwise. So you have to make sure that it is not an open globe injury. So intact conjunctiva does not always exclude a scleral wound. So you should know this. Look for it. Conjunctival wound may be away from the scleral wound. And when in doubt, don't hesitate to post for EUA. Like this patient had a very small, inconspicuous looking medial canthal tear. But then when we took the patient under EUA, you can see the amount of ragged edges and the amount of avulsion that he has had. He also had a medial canthal canalicular laceration as well. So what do you look for in the anterior chamber? The cells, flare, hyphema, hypopyon, foreign body, all this you know. So each of it, like layer, go stepwise. Look for deepening of the anterior chamber, for posterior dislocation of the lens, or is there any iridodialysis like in this patient, or is there any shallowing of the anterior chamber? If there is a shallowing of the anterior chamber, probably there is a corneal tear. There could be a choroidal detachment, anterior subluxation of the lens, partial subluxation. Sometimes there could be a total anterior dislocation like this, or there can be a sphincter tear like this, and sometimes a small buttonholing of the iris. When there is a buttonholing of the iris, what do you suspect? A foreign body. So that should be in your mind that there is a buttonholing of the iris, so that means there could be a foreign body. So have that in your mind that there could be a foreign body inside. So defects in the capsule, zonular rupture, vitreous in the AC, vitreous in like sometimes if they've had an old cataract surgery or something, there could be a vitreous in the section also. Now, checking the IOP is a bit of a controversial thing here. As I told you, ocular trauma is like loaded with controversies. You'll be amazed to know the amount of, the number of controversies that is there as far as the examination and the treatment of ocular trauma is concerned. So, grossly, if you feel that there is not much of a rupture globe, you could very diligently look for the intraocular pressure. So the low IOP indicates a scleral rupture, so we should be very careful not to put any pressure on the globe. High IOP could be having a closed globe injury, or there could be sometimes a pupillary block, aqueous misdirection can be there, but that doesn't mean to say that you should actively look for IOP. Please don't do that mistake of trying to do a digital intraocular pressure management or even applanation for that matter. It is detrimental and it is contraindicated in open globe. Examination of a retina could be a little difficult aspect, especially if there is a vitreous hemorrhage. You won't be able to see what is there behind. You might have to defer it sometimes, especially in open globe injury. You need to correct it first, correct the open globe injury, close the wound, wait for some time and then see. Again, likewise, even B-scan here, when you look at it, is a controversy whether you really need to do a B-scan. But some people say we can, depending. Again, it is tailor-made to the patient. You can't really generalize it. So what is now coming to the pathophysiology of trauma? This could be your exam question in what is the pathophysiology in rupture globe. So it's called the inside-out mechanism, where there is an ocular compression which leads to the momentary increase in the intraocular pressure and the globe gives way. Where does it give way? Huh? Sorry, I can't hear. At the insertion of the recti and so laceration will be because of the sharp object, and it is an outside-in mechanism. You must have heard about this coup and counter-coup a lot of times, especially in our forensic medicine, where the local trauma coup is like the local trauma at the site of the impact, whereas a counter-coup is opposite to the side of an impact. Ocular compression, which happens in the anterior-posterior direction. As I told you, it expands in the equatorial plane and ruptures. As you said, it is mostly at the insertion of the recti. And oscillation can cause vitreous-based avulsions and choroidal ruptures. Descemet's, lens capsules, zonules, Brooks, all this can take up trauma to a certain extent. Beyond that, they give way. Like, so if you see here, this patient had an old cataract surgery done, and because of the trauma, the intraocular lens expulsed out, and you can see some amount of iris incarcerated in it. They could have hemorrhages at the disc, optic nerve avulsion they can have, and if they've had any previous injury, it can rupture at the site. So you have done the basic evaluation. Now comes what do you want to do, image, to see if there is a foreign body or not, or if there is a fracture or not. What would be your first choice? What is the first choice that you think a patient should have, the imaging? I give you 3 choices: X-ray, CT scan, MRI. X-ray. How many of you for X-rays? Raise your hand. Why X-ray? Can you tell me why X-ray? The girl there, you raised your hand. I can see only you. The light is glaring. Why do you choose X-ray? The one in the stripe sweater there with the headband. Yeah, you, right. Why do you want an X-ray? To know the foreign body, if the foreign body is there or not. Right. What is the disadvantages of an X-ray? Yeah, see, now the plain X-ray is actually obsolete. We don't really advise or ask for a plain X-ray unless you just want to rule out foreign body, whether foreign body is there or not there. That is all. Beyond that, X-ray does not give you any clue in the management aspect. Most oftentimes, it is the CT scan that is considered the reference standard these days, because it not only tells you how many foreign bodies are there, it also helps you in localizing the foreign body, and also gives you where if at all there is any fracture, if there is any entrapment in the fracture, it gives more detailed information that we require in one single shot, of course. But now, again, here, as I have mentioned here, now there is something called as thin slice helical CTs, wherein the exposure radiation is minimized. Of course, I don't say it is not there at all. It is minimized. So, as I told you, the advantages would be to detect the foreign bodies, ideal for fracture, so you'll know where the fractures is, whether it is one fracture or multiple fractures, how deep is the fracture, whether it is anterior, mid, posterior. You can go up to the orbital apex to see. Sometimes you can even see if there is a traumatic optic neuropathy concerning the bone aspect. And there are a lot of downside to it as well, like it's not advisable in pregnancy for the sake of radiation. Soft tissue is not very sensitive, but an experienced radiologist can roughly tell you what could be the foreign body if you give him a rough idea what was the probable foreign body that you thought could have been there. Vegetable and organic matter is not readily visualized, but there is something called as a Hounsfield unit that I'll tell you about. That gives you what could be the probable material also. Like wood, there is a certain Hounsfield unit that they can tell like this could be the wood. Ultrasound, again, is, as I told you, is a bit of a controversy when it comes to open globe injury, although there are some retinal specialists who say we can put a blob of vitreous on the eyelid and do a very gentle ultrasound, but again, it is a controversy. It gives a real-time image with good resolution, especially for the lens, globe rupture, intraocular foreign body, or if there is a retinal detachment. And it's much less expensive, but of course it requires a lot of skill to read it. And there was a paper by the Academy of Emergency Medicine which said that there was almost a specificity of 97.2% for ocular pathology when they did an ultrasound. So MRI it does have some amount of role, but it's a little less useful in acute stages and should not be done, especially when you're thinking in terms of a metallic foreign body. Why? Yes, because it can move. So that is why we generally don't say. And then it becomes a little difficult to locate the foreign body. So that with that aspect, it might not be of great use. And the management planning. So most of these patients come to us out of chance rather than by choice. So you have to establish a good amount of rapport with the patient, not just with the patient, but with the attender as well. The nature of the injury, the implications, the prognosis should be explained. Witness for the consent is very important for the medico-legal aspects. And if you feel that your center has got a good surgeon who can handle it, who has got a good setup and capable, know your limitations, and then plan for the procedure. The protocol says that the absolute emergency is chemical injury, expulsive choroidal hemorrhage, orbital abscess, and an expanding orbital hemorrhage. Expulsive, choroidal, and orbital hemorrhage. So these are the absolute emergency that you need to do immediately. The rest fall under urgent, within 24 hours, 24 to 72 hours, and within 2 weeks and such. The preferred method of examination, or even sometimes your treatment, would be under general anesthesia for reasons that are quite obvious. Though in an open globe injury, restoring the anatomical integrity is the main factor to reduce the risk of infection, to avoid further injury to the intraocular contents, and preventing excessive corneal scar, and astigmatism comes at a later point. So ideal suture would be a tenno nylon. Recognition of anatomical landmarks, the limbus, the stellate edges and pigments, all this gives you a clue as to how to align it. So understanding the effect of sutures on the tight sutures, loose sutures, how do you need to place the sutures, and all these sutures need to be at right angles to the injury, burying of the knot, and the other one is the Roske-Hayes technique. Does anybody know what that is? Okay, bow tie. I've written there bow tie. How should the bow tie be? Well, the central one, when it comes to the visual axis, should be a small stitch compared to the ones at the periphery. The periphery ones are the long, straight, compressive suture bites. And whether you want to abscise the iris or not is again at that particular patient, it depends. And again, if there is a rupture of the anterior lens capsule, when do you want to remove it is another controversy as well. So sclera, some people say 8O vicryl, some say 10O nylon, but the idea is to expose and close as you go. So exploration is very important. Sometimes you might have to even look behind the recti, see where it is, look for the sutures, look for the tear and then suture it. Vitreous to be amputated at the scleral surface, not to pull it and cut. And if there is any uveal contents or if there is retina and other things which is there, it is better to reposit. You have to reposit. No better, you reposit. Postoperatively, a broad-spectrum antibiotic, IV steroid, cycloplegics. Again, all these are for the patient, for that particular patient, whether it's infected or not. It depends on that. So now when you come with an open globe injury, the wound is exposed. If there is no tissue prolapse, clean and suture the wound. That is the concept. If there is an iris prolapse, if it is non-contaminated, you can reposit if it is viable. If it is not viable, you abscise it. Choroid retina prolapse, reposit all of it that is possible. If there is a vitreous prolapse, excise in flush with the scleral base. Traumatic hyphema is something that we all encounter, whether it is a blunt trauma or if it is a penetrating injury, we do encounter traumatic hyphema. So how do you grade hyphema? Now you have the picture there, but can anybody tell me how do you grade? Okay, look at the picture and grade it for me. Huh? What? Okay. Yes, I can hear you. Excellent. What is grade 4 called? 8 ball. Why is it called 8 ball hyphema? No. Yes, it is 8 ball of the billiards. And that is what color? Black. So that is why it is called ball of 8 hyphema. So what are the complications of hyphema? Is again, rebleed is what we are most oftentimes worried about. It is associated with higher complication rate in larger hyphemas, young patients, Hispanics, sickle cell anemia patients, black patients on aspirin, and in patients who present more than 24 hours after injury. These are the patients that you should be a little wary of and watch for rebleed. And glaucoma can occur in these patients. Why? There is better to initiate therapy if the IOP is more than 30 millimeters of mercury in acute and 25 millimeters of mercury for more than 5 days. You have to initiate therapy. Angle recession of more than 180 degrees can again cause glaucoma. Corneal blood staining is another thing that happens if the IOP is more than 25 millimeters of mercury for more than 6 weeks. So the earliest sign of the corneal blood staining is a straw yellow discoloration, which is like, central deep stroma, and slowly it proceeds and it becomes a deep yellow. So initial red coloration is because of the extracellular hemoglobin and oxyhemoglobin in the central deep stroma. And subsequent brownish color happens because the oxyhemoglobin is converted into hemosiderin within the keratocyte cytoplasm. And clearing happens from the periphery to the center and takes almost 3 years for total cleaning. Optic atrophy can follow if the traumatic hyphema is, if the intraocular pressure is more than 50 millimeters of mercury for 5 days or 35 millimeters for 7 days, and PAS for more than 8 days. So the management guidelines, again, we have a lot of thing which comes again with the supportive care, the various investigations that we need, what are the medications that you give and you don't give. More than giving, the don't giving is very important here. And when do you intervene surgically? So moderate activity with head and elevation and shield is what they recommend. Even if you don't shield them, it is okay, but they say not to patch. So investigation, both the complete blood count, platelet count and all that. Medications, no aspirin for the simple fact that they can rebleed, so no aspirin in these patients. Surgery you can do if IOP is not under control, and usually it is the paracentesis and the AC wash. So when do you intervene surgically? When the intraocular pressure is greater than 60 millimeters of mercury for 2 days, or if the total hyphema with the intraocular pressure of more than 25 millimeters of mercury for 5 days, or if there is a microscopic corneal blood staining, and if the hyphema fails to resolve to less than 50% of the anterior chamber volume by 8 days. So this is when you surgically intervene. So what are the other factors that can cause glaucoma in trauma? Would be traumatic uveitis, trabecular meshwork, disruption, hemorrhage, lens-associated like lens-induced glaucoma, angle recession, inflammation, pupillary block, and even insiderosis. So how do you treat now, whether you want to do a trab or without, a trab with and without mitomycin, again, depends upon the significant amount of angle damage which is there. If there is a good amount of damage and extensive injury and your glaucoma is not under control, probably you can do a trab with anti-metabolite and relatively mild a trab without metabolite. If there is a good control with the medication, probably you should stop with that. Now with the injury to the lens, when you see a patient with injury to the lens, these are the things that should go in your mind. These are the things that you have to look for. First of all, is there a lens? Or if not, where has it gone? Like, has it come into the anterior chamber? Has it gone into the vitreous? How is the anterior capsule? Is the lens opaque? Is it visible from in the posterior chamber? Is there any vitreous, phacodonosis, subluxated? I mean, because all these things is what should run in your mind for your subsequent management. Should we remove the lens at all? What do we do if it is cataractous? What is the approach? Is it possible to implant the IOL in the first sitting? Primary implantation of the IOL is again another controversy in trauma. Probably a small localized opacity in the periphery without embedded foreign body can be left alone and wait for it to come into the visual axis, and then you can think about it. Primary lens removal is if the anterior capsule is so badly broken that the lens material leakage is there, you can think about the primary lens removal. Again, this is a controversy. What happens if the posterior capsule is ruptured, and what happens if the wound gets infected? Could it go into the vitreous is the main concern. And if the opacified lens in the young, why do you want to remove the lens if the patient is young? So what? Amblyopia, yeah. And if it is prolapsed into the anterior chamber, definite indication for you to remove it. And it becomes very challenging if there is vitreous, and depending on the patient, younger the patient, the more challenging it is, and if they require any additional vitreoretinal procedures. So primary implantation is usually not recommended if there is a severe inflammation, endophthalmitis. All these are a total contraindication to implant the intraocular lens immediately. You can wait for the wound to stabilize and then probably implant an adequate number intraocular lens. So if it is dislocated into the posterior chamber, better to remove it within a week because the results are much better. Dislocated IOL should be removed with vitrectomy, so couple with your vitreoretinal surgeon. As I told you, trauma is a multidisciplinary approach as far as the ophthalmology is concerned, not to hesitate to take any help from any of the subspecialists. So macula and retina, you could now, before I go into that, maybe one by one you can tell me what could be the possible retinal problems that you can encounter in a patient with trauma. RD. Berlin's edema, excellent. Dialysis, then. Choroidal rupture. Hemorrhage, CD. Then. Excellent, good. So let's see if we have completed that. Choroidal rupture, you said? Yes or no? Yes. Suprachoroidal hemorrhage, peripheral retinal breaks, commotio retinae, chorioretinitis scleroptera, somebody said that, traumatic macular hole, retinal dialysis, vitreous base avulsion, RD, and who has heard of Purchase retinopathy? What is Purchase retinopathy? Trauma to the chest, yes, it can cause Purchase retinopathy, yeah. And retained intraocular foreign body can cause endophthalmitis, RD, and metallosis, so it's very important. The current concept is to remove the retained intraocular foreign body, however benign you feel that it is, especially when it is in the vitreous and the retina. So the ocular signs would be the corneal wound, localized lenticular opacity, iris hole, heterochromia, pupillary asymmetry. Always rule out intraocular foreign body in any patient with trauma who you're suspicious of that there could be a penetrating injury. You have to rule out foreign body. Otherwise, you can get into trouble with the medico-legal portion of it. So you have to image them, and CT scan is the way to go. Management of the intraocular foreign body requires immediate closure of the globe and removal of the IOFB. Delay for anything even more than 24 hours can cause endophthalmitis, so you should be really careful about it. Broad spectrum IV antibiotics. Now again, whether you want to give intravitreal antibiotics or not is again a controversy, especially if there is no infection, signs of infection. Some say you should not give intravitreal antibiotics. Some say yes, you might have to give intravitreal because we don't know what the foreign body is. So that is another controversy. For you to know what are the types, how many controversies are there in trauma. So the removal depends upon the location, size, type, number, associated conditions like cataract, vitreous hemorrhage, retinal tear, and detachment. So you have to consider each of these points when you're thinking about removal of the foreign body, intraocular foreign body. Now comes the interesting part as far as I'm concerned. So the lids, adnexa, and orbital trauma. Actually, if you look into any of these, the BETT, the ocular scoring, and all that, most of them have very consciously not included lid, adnexa, and orbit into it. I don't know for whatever reasons, but then they say that if you have an orbital trauma or if you have lids and adnexal trauma, that is against the visual outcome in a patient. But I fail to understand why it has not been included in the basic trauma scoring. So you have to look for the retained, if there's any retained foreign body, lid margin repair, look for the ocular motility, as you all told, why we need to look for ocular motility. Eyelid movements, because traumatic ptosis can be there in eyelid movements. Tear passage is very important. Very small medial canthal tear can have a lacrimal, you have to check for the lacrimal patency, and you have to diligently look and know about the fractures of the orbit. So a margin tear like this, if left untreated, can give an ugly scar, and the alignment is very important. So what is the alignment key that you think of when there is a lid margin tear? What anatomical landmark that you have to reposit? Gray line. Where is the gray line? In association to the meibomian glands, where is it? Yeah. So the gray line alignment is very important. Three sutures, that is at the gray line, anterior to the gray line, and posterior to the gray line. Usually I use a 6-0 silk because we need that to stay at least for 2 weeks. Otherwise, your tarsus will not heal and it can give you a notch. And what are the other things that can happen if you don't align it properly? What happens to the lashes? Trichiasis. What is trichiasis? Right. Okay. So even a bad trauma like this, if aligned properly, can give a good cosmetic appearance. So alignment is all that is required in a lid tear. It is like a jigsaw puzzle. Don't take off anything. I have seen PGs telling that tissue not viable, excised. Please do not excise anything in the lid. Probably the only tissue loss that can happen in a lid tear is in a dog bite. Very good. It can happen in a dog bite and also in a very bad road traffic accident where the patient is pulled along the road. But even then, there you can still see the tarsus and the tarsal alignment can be done. So examination is very, very important, and not to tear away and snip away the lid is the criteria. I told you not to discard any eyelid tissues. That's very, very important. And again, whether you want to do acute skin grafting is still a controversy because we don't know whether it takes up or not. You might have to do an additional procedures later. And a medial canthal tear. Please look for a canalicular laceration in this because otherwise you wouldn't want to leave the patient tearing all the life. you have to see if the canaliculus is torn or not, and if it is torn, it can be easily stented with what we call as a mini Monaca stents, which is like available now like this, which is a silicone stent which has got a plug here which can be plugged into the canal into the punctum, and you can thread it along the canaliculus and a pericanalicular stitch be put, and this can be removed after about, say, 2 weeks. No, not 2, up to 4 weeks you can keep it. What do you see in this? What should have not been done in this? The first picture. The first picture was sutured elsewhere. What should not have been done when you look at this picture? Quick, I'm running out of time. Huh? What they have done which should not have been done? Probably sutured, I'll give you a clue, probably sutured by a general surgeon. Yeah, somebody said that. Eyebrow. Never shave the eyebrow. The general surgeons have got this concept of shaving the eyebrow. We don't shave the eyebrow simply because we fail to get the alignment. That's very important. As far as the aesthetic portion of the eye is concerned, it is very important. So never to shave the eyebrows. And if it is sutured badly like that, don't hesitate to remove it and resuture it. So you can see the pull here. If you leave it like this pull here, the patient can have lag ophthalmos later, and it requires an additional procedure, and you have to do multiple Z-plasties and those kind of things. So if you feel that it has not been aligned properly, feel free to take it out. If you can't handle it, please send it. Again, if the lid margin is not aligned properly, you can have a ectropion like that, as Z-plasty was done, and you can see down there. If you can't do it, please refer it, not to give a bad primary suturing like this. They have done a primary enucleation in this patient, and you can see how they have aligned the lid. You see this medial lid is gone inside the globe. I mean, it is not supposed to be there. Or other extreme is not to suture it at all and leave it like this, where the medial portion of the lid was avulsed. Then a note on fractures. A blowout fracture can be pure and impure, and a white-eyed blowout fracture. What is a white-eyed blowout fracture? Huh? No, it's seen in children. They don't have the subconjunctival hemorrhage. It looks absolutely white. Unless you look for the motility in the children, you might miss it. It might look grossly orthophoric, but if you ask the patient to look up is when you will feel that there is an entrapment. So pure blowout and impure blowout, I'm sure you know. Do you know? Do you want me to tell you? What is impure? Rim. Involvement of the rim is impure blowout fracture. So again, as I told you, you have to look for all these things, the ocular motility, the enophthalmos, diplopia. And what is this classic sign called? Teardrop. So this is a teardrop sign, and it is seen very well in a CT scan. So this kind of a picture you'll never get in an X-ray, even if you look at it, because there is so much of overlapping of the bones. So what we do is an open reduction and internal fixation with plates. And what are the types of plates used are various ones. We use silicone, we use titanium plates, and usually we prefer a transconjunctival approach wherein there is no scar, so you don't have to get any scar from the outside. So this was another, I'm sorry I don't have a preoperative picture of this lady. She had a medial wall fracture, so I went in a transcaruncular approach and put the plate in, so you can see the full movements that she has and the pre and post diplopia. This is a confusing diplopia. Don't try to read this because she had multiple muscle thickness and because of the inflammation, and it gave a very confusing diplopia charting. But you can appreciate the amount of diplopia that is reduced after the fracture reduction and with amount of steroids. So orbital foreign bodies is again a high index of suspicion, especially in gunshot, blast, metallic, non-metallic foreign bodies. So you should know what are the presentation is, the pain on movements. They can present with orbital cellulitis, restricted ocular motility. They can have fistula, discharge, diplopia, ptosis, and even lag ophthalmos. So this patient had this huge glass piece embedded in his orbit. It was almost into his cranial cavity, and he had a discharging sinus. So we had to, and this was the removed foreign body from the same patient. So MRI to be avoided in case of suspicion of a ferrous or a magnetic foreign body for obvious reasons that we know. And localization of the foreign body is very important, and that happens again with your CT scan, so you will know where exactly you can even position the foreign body. So this was another iron foreign body, and this was a bullet injury which went in. You can just see all he had was this small conjunctival tear, and this foreign body had grazed through his orbit, and it had gone into his lacrimal lamina pepraceae, and it was almost in the maxillary sinus, ethmoidal sinus, so we had to remove it. So basically, eyelid trauma can be as subtle as this, or as obvious as this, or as inconspicuous as this. Can anybody see anything in that? Yeah, there is a bird there. So if you look at it, look for it, you can find it. So that is supposedly a Sri Lankan frogmouth, and a very rare species found. It is found in India as well. So a traumatic optic neuropathy, a short note on this, induced injury to the optic nerve occurring anywhere along the nerve's intraorbital and the intracranial length, and the hallmark of it is the decreased vision, partial or complete, again temporary, or it could be permanent, it can be immediate, it can be delayed. So it has a huge spectrum. Loss of visual fields. Look for RAPD. Unless you look for RAPD, probably that is the only sign that you can immediately get it, especially if the patient is a bedside bound. You can still check the vision with the near vision card. So classifications.
Just sum it up.
Yeah, we'll sum it up. So again, this is direct and indirect. The site of injuries, depending on where exactly it is, anterior or posterior. And there could be associated multiple system trauma. Color vision, look for visual fields if possible. As I told you, RAPD, and investigations are your VP, VR, CT, MR. So compression, I think we'll skip the pathophysiology. You could probably read it in your books. And management is the current management would be the steroids. And retrobulbar hemorrhage is again a lateral canthotomy. Cantholysis has again got controversy in it, whether you really need to do, because a negative pressure can bring in more blood is what they say. And if you're in doubt, especially with ocular trauma, it is always good to have a damage control team, form your own team, and feel free to discuss with each of them, get to know what to do if you can't handle it, and if you can even refer to them and take the help. Thank you. So we will skip the sympathetic ophthalmitis. There is a talk in the APOTS tomorrow, so you all can attend that to know more about sympathetic ophthalmitis. Not tomorrow, on the 8th. Thank you.
Thank you, Dr. Tara. Does anybody have any questions for Dr. Tara? As she said, this is a topic full of controversies, so...
Yeah.
No questions? Then we move on to...
Thank you.
Thank you, Dr. Tara. We move on to Dr. Krishna Prasad, who's prepared a phenomenal quiz for us. And I have seen many people just walking in, and I think they've come just for the quiz. From Hubli, Dr. Krishna Prasad, sir. Over to you, sir.
Thank you, Saumil. So this quiz is always a refreshing one because it's informative, it's recreational, and also it allows some sort of self-evaluation. So I really pity all people who have been sitting through the day. I mean, hearing a long lectures, 45 minutes is really quite a hectic ones. But this, I assure you, will be having two parts. The first part, I'll go through the quiz very quickly. You don't have to form the teams. Each one is a team by itself. Okay, you are a team by yourself. Take a book, just write down the answer yourself. Within 10 minutes, we go through the entire set of slides, and I'll come back to each one of them. We will discuss each answer, and also I will have a complementary question for each slide, one more, which you have to shout it out. I've been really, disheartened. You have been very sedate, very laid back, absolutely not talking. Dr. Shruti tried really hard to make you people speak, but this time it's going to be different. Okay, enough of, now you've eaten a lot of agra petas, now you're going to really shout out the answers when I come back to that each question once again. Okay, so here we start. Can I have this mic on? Okay. So I'm very glad that we are in the place which is having a monument which is one of the wonders of the world. Okay. So let us start with, try to wake you up people. Can you answer this, anyone who is Somebody who knows the recent list of wonders of the world? Anybody? It's one of the wonders. See, very simple, man. It was voted out on online, okay? So India has so much of population. We voted for Taj. China voted for Great Wall. Brazil, a huge populous country, voted for Christ the Redeemer. Okay, in this, the poor Eiffel Tower got out. Okay, Petra, Machu Picchu, Chichen Itza, they are all in the new entries of 7 wonders, and Eiffel Tower got out. So, okay, we really don't know. It's only by, okay, the more population in the country, anything can get into the wonders probably next year. Now I'll start with, round 1. So just take your whatever you have been writing those notes on, just write round 1 and write 4 answers, one after the other. I'm going to just quickly go through this and we'll come back to each. Probably this is the only session where you can, within the shortest time, you can cover the entire ophthalmology and get the right kind of answers. Can you identify this ocular condition? The name of this ocular condition. Just write down. I'm only just going to give you 10 seconds. You have to write, this is a very unusual photograph. See clearly, write the name of this ocular condition. I think I'll go to the next one. This is a post-trauma condition. Can you specifically name the clinical condition? This clinical condition is a post-trauma sequelae. You just heard so much of trauma, so this is another traumatic sequelae. Just mention what is this condition we normally term it as. Okay? You don't have to tell the answer, I'll come back to that. How is this fountain in the vitreous? What has caused, or what is this fountain in the vitreous? Okay? You can just write your answer. If you just remember them, you can remember them. We'll come back to that. What has caused this very unusual fundus picture? Just look at this very carefully. This is a very unusual fundus picture. And what is the cause of this very unusual fundus picture? Okay? So we finish with round 1. There are only 4 questions in each round. We'll go to round 2. Okay? We'll come back to each of them. These are all fundus photographs. This is a bullseye. We can really get this. What is this clinical condition? This is the second one. Look at this carefully. What is this fundus picture showing? What do you see in this fundus picture? What is this characteristic macular lesion called as? This is probably the most commonly asked FA finding in your exams. What is this FA finding? Okay, this is just a trivia, just to wake you up from ophthalmology. In which English play you get the characters Antipholus and Dromio? Anybody knows the answer? There was a Hindi movie based on this play, yesteryears. The Hindi movie was called as Angur. Comedy of Errors, okay? In Comedy of Errors, that was Shakespearean play where you have this character. Okay, we'll go to round 3. This old man came with this lid condition. You have to name this lid condition, the name of this lid condition. You will have an additional question for each again. This is a very characteristic congenital problem. Name this syndrome. Identify this lower lid condition. The diagnosis. This child has a pulsatile proptosis. What is the likely etiology? We'll go to round 4. I just want to draw your attention to a midline calcification. The rest you have to see it yourself and give me what do you call this condition as? There's a midline calcification, and the rest is for you to see. And I want this a rare clinical condition. When this patient was received in the ward, the PG was searching for a stethoscope. So what is this clinical condition? This patient, again a trauma, I think Dr. Shruti's talk I am continuing. This patient came with a blunt trauma and was found to have no perception of light. So what is this post-trauma sequelae? What is this corneal treatment? Can you identify this corneal treatment? Okay, so I think somebody, movie buffs, anybody can tell the answer? Oh, this is very disappointing. You are all too good in ophthalmology. Kamala Hassan with Ravina Tandon. Huh? No, that was different. That is Kamala Hassan with, I think, somebody else. Manisha Koirala. This is a movie called Abhay, where Kamal has actually done a double role. Okay, now round 5. What is this ocular condition termed as? Okay, the ocular condition, what do you call this ocular condition? Okay. Can you tell me the diagnosis of this strabismus? The actual specific diagnosis of this childhood strabismus? What could be the cause of this eye condition? What could be the most likely cause of this eye condition? Identify this intraocular lens. Now round 6. What is MK506? This is the name of a drug that we use in ophthalmology. During its trial, it was called as MK506. Can you identify this drug? No. Your turn will come. What is actually 6 in a Hypersol 6 ointment? In a Hypersol 6 ointment, what is this 6 stand for? No. You're not supposed to know. We'll come to that. We'll come to each of them. Where do you find the rush disease? The rush disease in which clinical condition? Why do you get glaucoma if you eat Mexican poppy? Okay? So this is a trivia. Can you identify this person now? He looks like this now. And few decades ago, he was looking like this. Rakesh Sharma, yes. This is a, okay, you have to scramble this. I have to unscramble this word. Anyway, this, you can tell it right now. Can somebody unscramble this? This is an ocular condition. Oh, CMV retinitis, great. Now, yes, siderosis, great. This, cataract, that already shows the way you are actually, going in, right? So, cataract, you are at the drop of the hat. So, when you do cataracts, beware of this, okay? Endophthalmitis too. So, round 8, This is just write it down, you don't have to tell. This is a multiple choice question, you have to choose one. Tinu syndrome is, just choose Tina Nusselblatt, thoracointestinal neuropathy and uveitis, tubular intestine, okay? And second one, what is false about the stimulus size 3 in the Humphrey perimetry? It's used in swab, the size is 4 millimeter square, it is shown for 200 milliseconds, and it is a standard parameter. So only one is correct. You have to, you have to choose one from these 4 choices and keep it with you. In a pigment dispersion syndrome, the deposition of pigment along the insertion of zonules or a posterior capsule is called as Sampolisi's line, Shee's stripe, Chander's line, Orther's line. Okay? Just you have to choose one from these 4. What is false about Ahmed glaucoma valve? It has to be primed before insertion. It is used in epithelial downgrowth with glaucoma. The tube has to be placed in anterior chamber only. It is placed inferiorly in silicone oil induced glaucoma. So one answer you have to choose from this. Okay? So we'll have last 2 rounds now. This patient gave a history of a cataract surgery in a camp. So what could be the most likely cause? This patient has arthritis. So what is the clinical condition? What is the finding, okay, of the iris? What do you name this, okay, iris condition or this clinical condition, which is so characteristic in this photograph?